Hey Yusuf, hey Omri, how are you guys? How's it going? You did ample self-assessment, free this week, 3 days left. Yeah, I signed up for it. I'm gonna do it Saturday. Saturday, inshallah. Today is what is it today? Today is Thursday. I'm gonna do it Saturday after tomorrow, inshallah. By the way, what is this? Be right back page. Yeah, I change it so that when I'm going, when I go to get coffee or whatever. I thought I was watching Jimmy Kimmel's show. Sorry guys, I'm talking to one of my students. 1 second, I'll start doing questions right now. Alright. I actually feel way better when I'm doing cards. Because these things I haven't learned. Like a lot of these things I haven't learned, so I have to repeat it like 4 or 5 times. So by the way, I should be starting step 2 prep this week. Is there a specific order of systems I should go by, or it doesn't matter? My advice is do random blocks until you feel, oh, I'm weak at this, I'm weak at that. So I realized I'm weak in OB-GYN after like 10 random blocks. I see that consistently. I get OB-GYN questions wrong, OB-GYN questions wrong. So doesn't matter. Start with psychiatry or OB-GYN though. Whatever you're weakest at. If you get that out of the way, you'll see a boost of improvement. So okay, low dose molecular heparin. I hate MSK ortho. Yeah, see, you know what you hate. You know what you hate so much. So come on, I love MSK and ortho. I hate cardio. I hate cardio really. Like in my course, I didn't teach cardio. I got someone to teach cardio for me, so to completely avoid it. Well, cardio is the king of systems. Yeah, because I was in the U.S. at the time. I didn't attend medical school lectures of cardio. Okay, so okay, odorless, copious white, echoid, 3 days. Turns after the end of menses. Yeah. 10 to 14 days. Sounds like Gardnerella. So there were no PMNs and a lot of squamous cells, and there's a copious white odorless charge. So this is physiologic. I want to check for something now. Yeah, it's fine, bro. You're gonna see a lot of new news every day. Mid-cycle around 10 to 14 days after the end of menses. 10 to 14 days. Yeah, that makes sense. Is the KOH? No, it's a distractor. I think they're trying to let you know this is bacterial vaginosis, but yeah. So it has a fishy odor. It has a bad odor. All right, that's an easy one. I think I have some cards here. Physiologic. Does Adderall help to focus for long hours doing your work? I mean, I want to try it personally. I'm trying to get a prescription right now, but all I can get is Concerta. So, but my physician, he didn't respond to me when I sent him a message about Concerta. We agreed that he's gonna prescribe me Concerta, but he didn't respond to me till now. So I have to go to the desk, like to the office, but I'm too lazy to do that. Why do this? By the way, Mimi Real Deal Exam is obsessed with the fact that Canada does not change pH of the vagina. Oh yeah. See a lot of questions about that. Okay, so what do we do? Painful menses, pelvic blood pressure. Right, so I don't think we're gonna give her that abdominal myomectomy. That's for it's for adenomyosis, right? Submucosal. She's trying to conceive, so we will not give her that. I don't know, I feel like it's E or A. I mean, that is given in in uterine bleeding to avoid bleeding of the uterus. I'm not sure if it's part of treatment of that. Okay. Alright, so I eliminated B because she's trying to get pregnant. So let's see if I'm right. First line. Or not seeking fertility. They generally avoided in patients seeking pregnancy. Okay, I was right about that. C, it's not endometriosis, so. Endometrial ablation in uterine artery. Of completed childbearing. Oh, I'm getting step 2 questions right. Let's go. Yeah. Good job, bro. Endometrial ablation. Oh, you said A. Yeah. Endometrial ablation, uterine artery embolization. Digestion. Yeah, she cannot put IUD because she has distorted uterus. Okay. Alright, let's check the treatment. Wow, there are no cards. They love Leopoldine questions. I don't know. I didn't know this information, so. It's weird that even though leiomyomas increase in size by estrogen, you give her oral contraceptives. Is it because you give progesterone as well? Oh my god, these are very large, especially for prostate cancer. Yeah. Okay, I didn't know that. Right, I can't find any card here that's helpful. Rectovaginal culture is done at 36 to 37 weeks. I don't think we do it right now. No glucose and trace protein. 24-hour urine for total protein. No. 1 hour glucose challenge test. What is her red blood cell antibody screen? No, she's Rh positive. Repeat STD infection panel. Yeah, this is not done at 26 weeks. No way. I don't know about this. I mean, she has a husband and she has a son. There's no reason to doubt her integrity. Okay, I'll see why she's wrong. Yeah, 36 weeks. And D because she is Rh positive. This patient is Rh positive, okay. 24-hour urine for total protein. I don't know what even that even means. Indicated who are evaluated for preeclampsia who have renal disease. I mean, she doesn't have like hypertension or whatever. She doesn't have any symptoms too. 1 hour glucose challenge test. I guess we just do that to all pregnant women. Therefore, all non-diabetic pregnant patients are let me write that down or look for a card. Glucose test. Challenge. What is the best training? 50 grams. 50 grams. Okay, yeah. What is the best training for GBD? More sensitive than a fasting glucose. Yeah, here it is. 24 to 20 weeks. To all pregnant women. 50 grams. All right. Yes, that's a nice card as well. Normal 1 hour is less than. Yes. All right. Why is E wrong? Yeah. Hemoglobin / hematocrit for dilutional anemia and stuff, right? Where? Oh, you mean like in the screening or what? Oh, this one. Yeah, sure. Yeah. In pregnancy, females are susceptible to anemia. Even though their RBC volume increases, they have increase in blood volume, so they have dilutional anemia. Actually, that's a nice table. Yeah, that's RHT type. 50% increase in volume. Yes. Instead of 5 liters, they become 7 liters, 7.5 liters. So that's 50%. Yeah. Pap test. Yeah, group B is 36 weeks. Okay. Minimal variability, shallow, gradual decelerations after each uterine contraction. Hours after admission. So at admission she had 7 centimeter dilated. 2 hours later it's unchanged. Left lateral positioning, operative vaginal delivery. Saline amnion infusion. I mean, the contractions are fine, but it's not dilated. Maybe minimal variability. Left lateral position is for fetal hypoxia. I mean, he's kind of hypoxic, isn't he? Minimal variability, shallow, gradual decelerations after each uterine contraction. Isn't that grade 3 something? No late decelerations. All right. I don't know. I'll just pick E. Doesn't sound right, I guess. I feel it's not B because it's not 10 centimeter dilated. It's still 7 centimeter. C makes sense. Love you, bro. Keep up the hard work. Habibi House. Thanks, bro. Oxytocin. I was thinking oxytocin administration, but the Toko dynamometer shows contractions every 3 minutes. I think that's normal, right? All right. Okay, we are both wrong. This patient presents during labor with a fetal heart rate, minimal variability, and gradual drops that occur after each contraction. These drops are consistent with late decelerations. Damn, bro. You said no late decelerations, man. Yeah, it says after each uterine. So after each, so here's the uterine contraction. After it, you get deceleration. So that's late deceleration. Yeah, the sentence you highlighted is weird. Yeah. Minimal variability, shallow gradual decelerations after each uterine contractions. That's how they describe late decelerations. These drops are consistent. I overlooked the word minimal variability. Yeah. I told you there's minimum variability. Electronic fetal heart rate monitoring. Showing examples. Alright, so oxytocin. Alright, let's see if we eliminated it correctly. I eliminated C because the contractions are normal. And he's still, like, the cervix still didn't dilate. Where's C? Alright, I was wrong. I was wrong. Okay. Oxytocin. Late decel. An initial measure to treat fetal hypoperfusion causing late decels is to move from the mom into the left lateral position. Treat with intrauterine resuscitation. Specific aim. If this fails, do C-section. So I was right. I was kind of right about this. If this fails, like, we want to get the baby out, but if this failed, it's indicated, but is reserved for patients who have not responded to considered measures, such as in utero resuscitation, who are not candidates for operative vaginal delivery. Yeah, I was right. I'm so happy about this. I eliminated B because it's only 7 centimeters. Yeah, I'm gonna activate a card for this actually. A lot to unpack in OB questions. Yeah, bro, I'm telling you. Yeah, I've been 7 days right now in OB-GYN. I haven't finished yet. The management of category C is operative delivery. That's category C, what we're seeing right now, isn't it? I remember thinking about quitting STEP when I started studying by STEP. What is your plan B if you're not gonna do STEP exams? Are you gonna do MRCS, bro, and go to London and be a slave? Yeah, inshallah, I'll get through it. Inshallah. No, I mean, if you did, oh, okay, yeah, good for you. Only STEP exams, dude. Only America. Long live America. Cannot imagine myself except in the US. Yeah, I can relate to that. I have a lot of cards to do. Oh my god, bro. Look, 400. These are new cards, by the way. Okay. Not for the country for sure, but for the education environment they have in residency programs. I mean, there's nothing to be ashamed of if you want to come to the U.S. to live here. There's a lot of good things, a lot of bad things, but more than Arabian countries, here is better. You have Muslim environment too here as well, if you want. So, right, how to avoid getting this question wrong again? All right, operative vaginal delivery. I eliminated this. Oxytocin administration. She has late decelerations. If she has late decelerations, the first step is left lateral positioning. Second step, C-section if it didn't work. Saline amnion infusion, when we do that. Okay, I didn't know that. All right, let's see. Amnio infusion. All right, I didn't know that. Let's activate this card. Maternal positioning. Veal chop. Veal. Veal chop. Cord compression. All right, so left lateral position is the first line in both, actually. In variable decelerations and in late decelerations. Left lateral position is the first line. Reduce cord compression and peripheral is a reasonable second line. All right. I mean, it makes sense. If the cord is compressed, it makes sense to add some... I'll grab something to eat. Looks like I want to watch all the stream. Let's go, bro. Let's go. Yeah, it's not bad. When is amnion infusion contraindicated? Amnion infusion involves the placement of an IUPC variable deceleration. Okay, so first, I need a paper and a pen. I can't arrange my thoughts. One second. So cord compression is also associated with. One second. Hmm. Kind of lost here. I don't know the management.
Generic. Here we talk about intrauterine resuscitation. Intrauterine resuscitation is generic measures that are designed to enhance oxygen transport from the placenta and the mother to the fetus. Firstly, we want to decrease uterine contractions because the intravillous space is being compressed with contractions, and that's going to decrease the amount of blood flow. So if there is oxytocin going, discontinue the oxytocin. If she is having contractions but no oxytocin, give some terbutaline. See if we can space out the contractions. She may have an intravascular fluid deficit. Let's give a bolus of 500 milliliters of Ringer's lactate, normal saline. See if we can enhance the intravascular volume. Give high flow oxygen by face mask, 8 to 10 liters. See if we can increase the inspired oxygen concentration that the mother is breathing in. Change the position of the mom. If she's laying on her back, she may have inferior vena cava compression. Put her on her left side. If she's on her right side, maybe there's umbilical cord being compressed. Change position. Do a vaginal exam to rule out a prolapsed cord. This is particularly if you see variable decelerations or bradycardia. And the last thing is do a scalp stimulation. Scalp stimulation is very similar to the vibroacoustic stimulation. If you have a healthy baby, you will see accelerations. And the way you do scalp stimulation is to take your finger and just stimulate the scalp like this. Here we see a non-reassuring fetal monitor tracing. Many of these severe decelerations. What's going on? Notice the frequency of the contractions. They're coming every minute. This is uterine hyperstimulation because of excessive oxytocin. Shut off the oxytocin, what happens? This looks like a great tracing. Interventions which normalize the fetal heart rate. Certainly makes good sense. Okay, this is chapter 16, intrapartum fetal monitoring. We talked about antepartum fetal monitoring before. This is intrapartum fetal monitoring. When we look at intrapartum fetal monitoring, we're basically talking about monitoring of the fetal heart rate. And there are many different ways of doing this. The most common methods historically have been intermittent auscultation, where you use a stethoscope, listen to the heartbeat, you count for 15 seconds, multiply by 4, and you have the heart rate per minute. More recently, we've had external continuous electronic fetal monitoring and continuous internal electronic fetal monitoring. And we're going to look at each of these. The question I have for you is, which of these methods has the best outcome? And the answer is, they are all equivalent. There is absolutely no evidence that electronic fetal monitoring gives you a better outcome than intermittent auscultation, but we have got to where in our society, in America, the standard of practice is electronic fetal monitoring. And if you don't do it, then you're holding yourself out for liability action. And yet there is no good evidence that one is any better than the other. Here's a papa who is trying to hear the fetal heart rate. This is very difficult to hear because the fetal heart tones are a very low frequency, hard to hear. You've got to have a bell like this wooden fetoscope that I got from Amsterdam. Here is a metal one. You can see this is a little bit younger obstetrician. This is the DeLee stethoscope or fetoscope, which was developed by Dr. Joseph Bolivar DeLee. We use this for many years. You hold it with your forehead. The disadvantage, Dr. Joseph Bolivar DeLee. We use this for many years. You hold it with your forehead. The disadvantage is a mother can't hear the fetal heart. And that's a method of bonding, is for her to hear her baby's heartbeat. This is the Hahn fetal monitor. Edward Hahn was a graduate of Loma Linda University School of Medicine. He went to Yale University and developed this fetal monitor that cost at that time $10,000. This was in the late 60s, early 70s. You know what you could buy for $10,000? You could buy a house for $10,000. Why did Dr. Hahn go through all of the effort to construct this fetal monitor? The reason is, it was felt at that time that the cerebral palsy had its onset during labor. And if only we could identify the fetus that was in trouble early and deliver that baby, we could eliminate cerebral palsy. On the speed of wherever it is hitting. And if it's moving heart, which is reflecting the sound back, we're going to pick that up. We already talked about the external Toco device, which picks up the uterine contractions. And here's the patient with the external devices on. The advantage is the cervix does not need to be dilated, the membranes don't need to be ruptured, and you can do this before labor. The disadvantage is it's not quite as accurate. If you have a 400-pound mama, you're not going to pick up the contractions as well as if she is 100 pounds. And the same thing with the fetal heart rate. For that reason, we will often use an internal scalp electrode. This is my thumb and my fingers. This
You're supposed to hear me now. Yeah, the mic disconnected. Okay, so this is Bartholin cyst. If it is less than 3 centimeter, we're not gonna incise it. Okay, we're gonna do this. All right, I got this question, a similar question wrong before. So, all right, let's see the management of Bartholin. Bartholin cyst. Asymptomatic and less than 3 centimeter. Symptomatic incision drainage. Yeah, posterior introitus, that's the definition. these cards old or what? They don't have the new guidelines. Recurrent. Okay, marsupialization. All right, so more than or equal to 3 centimeters. Catheter. That's a very nice pick. So obstruction and inflammation. All right. Okay, so she has heavy bleeding and cramps, so we wouldn't give her this one. Wouldn't have copper. Combined oral contraceptives are good for heavy bleeding. So male condoms, no. Progesterone only, oral contraceptives. She doesn't have any risk factors for estrogen. Actually, estrogen would be good in this case because she has osteoporosis. So this is yeah. All right, let's see if I eliminate it correctly. B is wrong because heavy bleeding. Let's see. Is on blah 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 blah. However, is associated with increased menstrual flow that could exacerbate. All right, I was right. C, we would want to give her estrogen. Decreased, however, it's associated with. All right, yeah, I said estrogen is better in this case because she is osteoporotic. And this is stupid. Male condom and progesterone would be safe, however, these forms are comparatively high. Yeah. So defines the most likely diagnosis. A swab of the fluid is smeared on a slide. So examination, arborization. I remember this. Arborization, I think it's just Candida. Large gush of fluids after sneezing. Small pool of clear fluid. Yeah, that just tells tells us she has ruptured membranes. Yeah, that just tells us she has. Yeah, right. Okay, so the small pool and the arborization is just pre-labor rupture membranes. All right, I forgot what arborization is, so I'm gonna look it up. Arborization. Okay, it's not here. Posterior vaginal fornix. Yeah, so here it's ferning. Here it is. Yeah. Here it is. You'll see with this either have choice of carrying the fluid, put a slide, see ferning. Arborization. All right, now. I need to go to the bathroom, guys. One second. back. You guys try to solve this one? All right, we cannot do forceps assisted vaginal delivery because she's 33 weeks. She has to be more than 34 weeks. Intravenous oxytocin. That will worsen the application of fundal pressure. Cesarean. I don't know. I think just cesarean delivery. By the way, I'm using your study techniques in step 3 and it's dope. You mean like what I'm doing right now? Okay, I think it's just cesarean delivery. Bro, he's 33 weeks. What do you mean? Oh, it's vacuum. I read it vacuum assisted vaginal delivery. My bad. Yeah. My bad. I read it vacuum, bro. It's forceps. Okay. My bad. How didn't I see this? What, like I don't have a brain? All right. Yeah, I mean he's 3 stations. He's like literally out of the pelvis. You just need some assistance. You have sessions today or all streaming? No, all streaming. I don't have any sessions today. Unless people like some people just sign up, but I'll not accept. I'm gonna study all day today. I'm not gonna do any sessions. Forceps assisted vaginal delivery. Okay. Forceps assisted. Let's see, category 3, I guess. Category 3. Okay, my headset is charged, I believe. It's done. Okay, 70%. Wow, 70% charged. Nice. Okay, let's keep doing this.
Is about the size of a 28 gauge needle. Very, very tiny. Smaller than an insulin syringe. We don't screw this into the baby's head. We attach it gently to the superficial layers of the scalp. Here we see the maternal QRS complexes, which are the large signals, and between them are the smaller fetal QRS complexes. Let me show you this a little bit better. You can see the big maternal ones. Look at the fetal ones. Here's one. This one is hidden. This one is hidden. You can barely see this one here. This one is hidden. Here's a fetal QRS. Here's a fetal QRS. Can you see these here? Okay. What the fetal monitor does, it measures the interval between the QRS complexes, and using a reciprocal function, it then comes up with an instantaneous fetal heart rate per minute. The fetal monitor does only one thing, and that's calculate the instantaneous fetal heart rate. That's all it does. It does it very well, but that's about all it does. Now, does it help the outcome? Here we have the scalp electrode, which is on the fetal head, and it picks up the QRS complex. We subtract the maternal QRS, and now we have the instantaneous fetal heart rate tracing. We can measure the strength of the contractions using an internal uterine pressure catheter, and here you can see the catheter goes down through the cervix into the uterus.
I've never seen
any idea here is
question about this, so I think he's just trying to tell us that
it's the hydrostatic pressure. The hydrostatic pressure should be equal throughout. Then the paper, which comes out the machine, has on the top the fetal heart rate, and here we have the contractions. And here's a patient in labor. I happen to know her quite well. Right here in this uterus is my son. This is my wife in 1976 in labor. And that's the end of fetal heart rate monitoring.
Okay. Evaluation. Yeah, here it is. Are you solving USMLE RX or no? I don't think so. Thanos is solving it, Yusuf Thanos. And he's saying it's so bad, like it's so hard, so difficult. So I don't know.
Let's look at evaluation of fetal monitor tracings. What is the likely fetal outcome with a reassuring electronical fetal monitor tracing?
Fetal outcome with reassuring.
A normally oxygenated, healthy baby. What is the fetal heart rate with a non-reassuring electronic fetal monitor tracing? A healthy or a sick baby? Most likely, it is a normally oxygenated fetus. There is a 99% false positive rate when we say that the baby's in trouble. Most of the time, the baby is okay. The electronic fetal monitor is a very good indicator of good fetal status, but it is not a very good indicator of poor fetal status. Let's look at our sequential steps in evaluating our tracing. The first thing we want to look at is baseline fetal heart rate. I think it's important to have in your mind a sequence that you always follow. First, we want to look at what the fetal heart rate normally is, which is 110 to 160. If it is faster, we call that tachycardia over 160. If it's less than that, it is bradycardia. The question is, are babies who are tachycardic in trouble? And the answer is not always. Are babies who have bradycardia in trouble? Not necessarily. So an abnormal fetal heart rate does not mean a sick baby. Baseline,
wait a minute.
Not necessarily. So an abnormal fetal heart rate does not mean a sick baby.
And step one, it was awesome. Yeah, it is. It was.
Baseline changes to fetal heart rate. This is what you'd expect with a normal fetal heart rate tracing, 110 to 160. This would be tachycardia, and you can see there's good variability of this tracing. And here we have bradycardia. And the important take-home is babies who have heart rates outside of the normal range are not necessarily in trouble. This is a great board question. You need to know this. What maternal medications can cause fetal bradycardia? Beta blockers are going to slow the heart rate of the mother and of the fetus. local anesthetics, such as with a paracervical block, we just talked about this, can lower the heart rate. Fetal tachycardia can occur with beta agonists, such as ritodrine, terbutaline, and atropine-like medications, parasympatholytics. Out of the normal range are not necessarily in trouble. This is a great board question. You need to know this. What maternal medications can cause fetal bradycardia? Beta blockers are going to slow cardia. Rate can occur with beta-methasone and corticosteroids. How about if the mother has systemic lupus erythematosus and she has anti-Rho, anti-La antibodies? This baby could have a complete heart block. And here is a fetal heart rate of 60s. Is this baby in trouble? No. It increases its stroke volume so it can maintain the cardiac output. It's important to remember that changes in fetal heart rate are not necessarily associated with poor fetal outcome. All right, we've talked about baseline fetal heart rate. Now we want to look at periodic changes. Periodic changes are changes in the fetal heart rate which are temporary, which are not changes in baseline, and will usually last no more than 1 to 2 minutes. We talked about accelerations in response to the NST, and those are always reassuring. And there are 3 kinds of decelerations. There is the early decelerations, the variable decelerations, and the late decelerations. Here are accelerations, and we've already looked at that. This is a rise in the fetal heart rate of 15 beats a minute or more, lasting 15 seconds or more, and they are a response to fetal movements. These are always reassuring. This is from sympathetic stimulation, and we're always happy to see accelerations. Decelerations, there are 3 of those we talked about. There are early decelerations, and this is a response to head compression of the fetus. The management is
Veal chop. Yeah.
basically, don't worry. These have no impact on the outcome. You can ignore them. They are seen more commonly after the membranes have been ruptured. Variable decelerations are a response to cord compression, the umbilical cord compression. These, if they are severe, are troublesome. And a severe variable deceleration is one that lasts 60 seconds or more, drops 60 beats a minute or more. Otherwise, they are not to be worried. Late decelerations are a response to placental insufficiency. And these are always troublesome, even if they are mild late decelerations. Let's look at the characteristics of these. In your notes, you have this tracing: early decelerations, variable decelerations, and late decelerations. In your notes, you have this tracing: early decelerations, variable decelerations, and late decelerations. The mechanism of fetal heart rate early decelerations, we already said, is head compression. This is vagal stimulation.
When are you taking step 3, let and research positions? Step 3? I don't think I'm going to take step 3 before residency. I can't. Bro, that shit is too hard. I'm inside my house all day. So miserable.
Heart rate.
I have to finish step 2 first.
Here we have a tracing. You can see contractions, and notice the early decelerations. The characteristic is that as the contraction begins, the deceleration begins. At the peak of the contraction, we have the lowest point in the deceleration, and then we have a gradual return. Notice that the contractions and the decelerations are simultaneous. They are superimposed on each other. Gradual drop, gradual return, a mirror image of the contraction. Variable decelerations are also mediated by the vagal nerve and are due to umbilical cord compression. Look at the difference in the appearance of variable decelerations and early decelerations. With variable decelerations, we have a sudden drop, a sudden return. I call this a box-like shape. Sudden drop, sudden return. Okay, the blue bars are the contractions, and here are the decelerations. Is there any systematic relationship between the deceleration and the contraction? No, they are variable. And notice they are sudden drops and sudden returns. Now this might be a severe. It drops 60 beats a minute. But this one here is what we call a carrot, of no clinical significance. Late decelerations are mediated through uteroplacental insufficiency, and these are always worrisome. Here we have the contraction, and here we have the deceleration. I want you to notice the baseline heart rate is about 170 to 180, so we have a tachycardia. Let me superimpose on here the decelerations. And what you see is the peak of the contraction and the lowest point of the deceleration are not synchronous. The deceleration is always late in relationship to the contraction. And that's true over here, where we have the peak of the contraction and the lowest point of the deceleration. You notice that the end of the deceleration is after the end of the contraction. So we have early, variable, late deceleration. So we've looked at baseline heart rate, periodic changes, and now we look at variability changes. This is a normal variability. These are the rapid rises and falls of the heart rate, which is a reflection of the interplay between the parasympathetic and sympathetic nervous system. This is healthy. Let me show you a troublesome fetal heart rate, and the variability is basically gone. It looks like you've got a ruler and you're drawing a straight line. This is not reassuring. Look at this tracing here. This is flat as a pancake. I don't like it. Look at this tracing here. Flat as a pancake. Let me draw a line across here, and you can see it is so flat. Decreased variability, not a good sign. The mechanism, we said, is the interplay between the sympathetic and parasympathetic. The sympathetic rises, the parasympathetic lowers the heart rate. Okay, so we've looked at baseline heart rate, we've looked at periodic changes, we've looked at variability.
I think I already watched this one.
Now let's look at reassuring versus non-reassuring. Decelerations of any kind, very to know. If you have a baseline heart rate, which is 110 to 160, accelerations are present, there are no decelerations of any kind, variability is good, you can be almost sure you got a great baby here, 99.9%. Notice we use the term reassuring. One of the concerns about using the term fetal distress when we describe a non-reassuring fetal monitor tracing is it is not precise. This is American College of Obstetrics and Gynecology Committee opinion. And what they say is the term fetal distress is imprecise and non-specific. And most of the time when we have a, quote, fetal distress pattern, the baby comes out screaming. Was it truly fetal distress? It was doctor distress. So rather than use the term fetal distress, we use the term non-reassuring fetal status and then describe what you see. So when we have a non-reassuring pattern, it may represent a baseline tachycardia, baseline bradycardia, it may be severe variable decelerations, late decelerations, absent variability, but this does not mean that the baby's in distress necessarily. But it is concerning. It is non-reassuring. What do we do about a non-reassuring fetal monitor tracing? Our last segment is the approach to non-reassuring electronic fetal monitor tracing. Now, we've talked about this briefly with our generic interventions that we just talked about. Here's our case. A 20-year-old gravida 1, 39 weeks gestation, is in the active phase of labor, 7 centimeters. The electronic fetal monitor strip shows a baseline heart rate of 175. Upper limits of normal, 160. So this is tachycardia. Variability is good, 7 beats a minute, but there are repetitive late decelerations after each contraction and no accelerations. Are you happy? No. Is this baby in trouble? I don't know, but it's non-reassuring. The first thing you need to know is recognize that most abnormal non-reassuring tracings are not caused by fetal hypoxia. Ask yourself, does the tracing have biological plausibility? What does that mean, biological plausibility? We have 2 patients. They both have the same tracing. One is a 22-year-old, prima gravida, healthy, no medical complications, no obstetrical complications. Second is a 41-year-old mom who's got chronic hypertension, type 2 diabetes. Which one of these women has biological plausibility regarding a baby that's not doing well? Obviously the second one. I'm going to be far more aggressive with the second patient, the hypertensive diabetic, than I will with a normal woman. Much more likely that it's going to be a false tracing with a young woman. Then, what do? Examine the electronic fetal monitor strip carefully. Confirm the abnormal findings. Is there tachycardia, bradycardia, severe variable decelerations, late decelerations, absent variability? If there is, identify are there non-hypoxic causes. Let's say, for instance, a mom has a tachycardia, the baby has a tachycardia, and she has a fever. Is this baby in trouble? No, this is a normal physiologic response. And we talked about the medications, beta agonists, beta blockers, local anesthetics, and so on. Is there an explanation other than hypoxia? If not, then we initiate our intrauterine resuscitation. Shut off the oxytocin, give terbutaline, 500 milliliters IV bolus of isotonic fluids, turn the mother on her side, give oxygen, okay, all that good stuff. Did it help the tracing? Does it look better now? If it does, great, you're done. If it doesn't, in spite of all of your interventions, we have the persistence of the non-reassuring strip. No explanation for it. You're basically stuck. If it's the first stage of labor before the cervix is completely dilated, it's going to be an emergency cesarean. If it's a second stage of labor, now we have potentially to do a vaginal delivery, vacuum extractor forceps, or an emergency cesarean. But if you cannot, with your interventions, get a reassuring strip, then you're basically...
That's important, actually.
Complete non-reassuring strip. No explanation for it. You're basically stuck. If it's the first stage of labor before the cervix is completely dilated, it's going to be an emergency cesarean. If it's a second stage of labor, now we have potentially to do a vaginal delivery, vacuum extractor forceps, or an emergency cesarean. But if you cannot, with your interventions, get a reassuring strip, then you're basically obligated to do an emergency delivery. And that is the end of...
Bro, watching these videos are very boring. They're not engaging at all, but they're very helpful too. I don't know what to do. I can't even watch them. So what QBanks are you planning to do? This Kaplan, Emboss UWorld CMS forms. He didn't mention the categories here. Bro, these videos cover everything. Do USMLE RX? It's good, I did it. What QBanks did you do for step 2? UWorld, USMLE RX, Amboss? Yeah. I'll do Kaplan instead of RX. And I'll do all the same. Did you do the CMS forms? CMS forms, did you do them? Bro, this is so high yield. CMS forms are exactly like the MBMEs. It's 2,000 questions, as if it is a new QBank on its own, in addition to the MBMEs. What banks did you do for step 1? I did 14 blocks of Your World. I did half a Wine Boss. That's it. And a little bit of RX, some blocks here and there. That's complete abortion. Which trimester is she? Oh, first trimester. It's an easy one. Your time in Egypt is incremented. Damn. What do you mean? What's your opinion on time bank? You get it wrong if you don't answer within a certain amount of time. I mean, it's stressful, you know. I wouldn't do it. I would take my time to think about it. You can try it. Time and carrier should be 6 hours behind. Us know it is 5. Rank the Q banks that you like from best to least. I do it for decks that I know really well. Helps me focus. Oh yeah, yeah. If you know it really well, then yeah. Rank the Q banks that you like from best to least. Your world best. Amboss next. Kaplan. I haven't done any except Kaplan, so I can't really say. But if you're asking what is the best, of course you know Your World. Your World and Amboss. Can't find a card about this. What is the price of USMLE RS subscription? I don't know. $349. Try to make the most of the day for cards and questions, but bro, do next block. Yeah, I will. I'll just I have a lot of cards today. It's gonna be a card day. I'm trying to get rid of these questions ASAP. Why students don't solve Kaplan like solving other Q-banks? I don't know. ازيك يا محمود؟ خير الحمد لله. اكسنت حضرتك جميلة اوي. ازاي حسنتها خصوصا وانت في مصر؟ انا كنت في امريكان سكول في مصر، فكنا على طول انجلش يعني. بعدين كنت بسافر امريكا برضو بعد 3 شهور الصيف، كلمت يعني براكتس بس مش اكتر.
I'm gonna take a break.
Come back to these questions.